Good evening, all of you, to the Weekly Huddle session 43. My name is Anup Agrawal. I'm an interventional cardiologist at Care Hospital, Hyderabad. I'm joined by my colleague and co-host, Dr. Praneeth Palamari. The Huddle is an unscripted audience-level interaction addressing common clinical scenarios, research, recent findings, news, lifestyle, amongst others. We aim to keep discussion on a particular topic, and we kind of share our ideas in terms of what we think about the particular question. The basic premise of the huddle is to bring our casual hallway discussions to a more organized platform like this one and share our ideas. While we do welcome science and guidelines, with the huddle we intend to help a physician translate established knowledge to clinical practice, taking local factors and practice patterns into account. And that's what we are interested in learning, individuals' practice patterns and why we make a certain decision the way we do. What we typically do is we pick up a case and a topic, and we kind of go around our attendees and get their ideas. The huddle is not a speaker and audience model, rather an audience level interaction, which means at any point, any of the attendees can raise their hands or unmute themselves to give their input. As a courtesy, you should wait for others to finish their thoughts before you unmute yourself. Having said that, I will start this case, and I will ask Praneeth to give his initial opinion, and then we will go around the audience asking for their opinion. So Praneeth, this is a patient I saw very recently. I saw actually this patient last week itself. He's a 76-year-old male. He denied any comorbidities. He's one of those patients who says, I never needed to go to a hospital for anything. He used to work as a security personnel. He's retired now. And he lives alone with his wife at home. For the past 2 months, he had been complaining of dyspnea, which initially got him worried that it may be COVID, which he got tested with RT-PCR, and that turned out to be negative. Somebody suggested to get him to see a cardiologist for his dyspnea, and that is how he came to me. He did not complain any chest pain or anything. His primary complaint was dyspnea for about 2 months. He did have some resting dyspnea as well, but it certainly got exacerbated whenever he would exert. He did not have any orthopnea, PND, or any other suggestion that might think that he is in a fluid overload state. When he came to me, he asked what all investigations I should get done. His rest of the parameters in the OPD were okay in terms of his blood pressure was fine, his saturation was okay. His physical exam has got some scattered crepitations, which I could hear, but nothing otherwise. His JVP was not raised. His heart sounds were okay. He didn't have any edema. So overall, I did not think he had any heart failure. He was a lifetime non-smoker. There is no family history otherwise, and he otherwise seems to be a reasonable person. So I did some routine investigations. Along with that, I did 2 specific investigations, and I will ask you individual questions about today's discussion. So I did a routine so-called master health checkup on him because I thought rather than doing individual orders, let's just do a complete package. That way it will save him some money. But I also wanted to take a look at his lungs. So I ordered a HRCT because of the crepitations I was hearing. And I thought that while he will be in the CT scanner, I might just do a calcium score on him. That will be a very low risk investigation to get an idea about his risk profile. So he came back to me with a follow-up, and I'm just going to read out the relevant findings for today's discussion. In his lipid profile, his LDL is 143. His non-HDL is 185, and that non-HDL is total cholesterol minus HDL. Typical cutoffs are 30 more than the LDL cutoff. He is non-diabetic, as I told you previously. His A1C is normal. His calcium score on his scoring chart came out 800, which was equally divided between the 3 arteries. His HRCT was suggestive of ILD with a non-specific inflammatory pathology, kind of distribution, which didn't look infective radiologically. And I was pretty much convinced that this ILD on the HRCT was probably the cause for his dyspnea. And I suspected his symptoms were probably longer than 2 months, not just 2 months that he was complaining. So I sent him to pulmonology for his ILD assessment. But while looking at him, I was also looking at his cholesterol levels and his calcium score. And the questions that comes to my mind is, and the same question I'm going to ask you. So the questions that come to my mind, 76-year-old male, non-diabetic, otherwise all right. How do we estimate his atherosclerotic cardiovascular risk? We know that we have certain risk algorithms, mostly for Caucasians and European population, like your Framingham risk or your pool cohort equation and all those things. But none of them extend for a 76 or 80-year-old. So while there are no algorithms, how do you assess ASCVD risk in these patients? And is there a role of pharmacotherapy for primary prevention in these patients? Remember, primary prevention is something that you start today and it works after, God knows, 5 years, 10 years, whatnot. So is there a role for starting pharmacotherapy for primary prevention of ASCVD event in elderly population, particularly 75, 80, who so far did not have any major comorbidity? Is there any other ancillary investigation that you would suggest to help make the decision? And role of angiography in these cases? Remember, he's not having any angina. His ECG echocardiogram is okay. I have not done any stress test on him. I didn't feel any need for it. But purely based upon high calcium score and a person who is dyspneic, but I am convinced that the dyspnea is most likely pulmonary in origin as compared to cardiac in origin. So Praneeth, here is the clinical case for you. I want to focus on primarily ASCVD risk and how to do primary prevention, but you are free to answer about the clinical presentation as well. Praneeth, all yours.
Yeah, good evening, everyone. So the way I look at it, Anup, is having breathlessness with some limitation. Probably that is why he came to hospital or getting evaluated, which to me is a significant symptom. Any symptom which made him come to hospital for evaluation is important, though he may not agree or though he may not admit as the important symptom it. So I would definitely consider that his breathlessness is significant and it needs attention. Now, evaluating dyspnea to major causes being pulmonary or cardiac, you already said symptoms all favor interstitial lung disease. I would try to look at his saturations, or probably I would, if possible, try to do kind of 6-minute walk test and look at whether his saturations drop, trying to favor more of pulmonary origin. Now, hopefully, if that is the case, then advise him with pulmonologist, and if he's significantly desaturating, then probably work on those lines about asking him to looking into oxygen and etc. etc. As a cardiologist, the question is about his uh, cardiac status, particularly coronary artery disease. Now, first question about evaluation of ASCVD risk. Most of the algorithms talk particularly on the age group of 40 to 75, but probably the same thing can be extended to other age group as well, understanding the limitations. So someone who is less than 40 also we try to apply, and someone more than 75 also you apply, understanding the limitations of these formulae or the algorithms. So I would still consider him for risk of ASCVD assessment, because I can at least see a lot of people surviving for 80, 85 in a reasonably healthy state, not bedbound kind of a thing, and they have a decent quality of life. So they should be given that better quality of life. So I won't step back just because of the age being 76. I would still, if he's physically fit enough, has a good quality of life, and he wants to have a lead quality of life, then I would definitely consider assessing his risk and equally treat him in a similar line while I'm treating a younger population. So he definitely has a calcium score which is significant. So there is a probability of coronary artery disease in him, and that dyspnea could also be an anginal equivalent. So I would first treat him, probably put him on a single antiplatelet, a moderate intensity statin, beta blocker or a nitrate, depending on treating in lines of chronic stable angina, and keep him under follow-up. If there is any improvement in his symptom status with the long-acting nitrate, beta blocker, and others, I would and the advice given by pulmonologist, I would be happy to continue. But if he continues to have symptoms, then I would have a low threshold to do a coronary angiogram on him, look at the severity of the disease, and if possible, equally offer a revascularization strategy. So for me, age, I usually do not consider or look age in isolation. Look at more about what is the physical status of the patient and all those things. Of all, the one thing which caught attention to me is that you said he was a security guard or something. That is where things will become tricky, where I believe that his finances would be difficult. So instead of ordering so many investigation, I would be erring more on giving him some treatment and keep him under follow-up and do investigations accordingly. That's all I have enough.
Thank you so much, Praneeth. And I would consider your approach as a little bit more active management, or aggressive is would probably be a wrong word, but certainly a more active management at his age. And whether to say that whether this dyspnea is angina equivalent or not, I don't think I have an answer for that. It certainly could be something that we have to look into. One tiebreaker could be to do a pro-BNP. I did not order it on the first set. I have ordered it now, which I don't have the report yet. But certainly a pro-BNP can help us a little bit, although I'm still fairly convinced this is not heart failure. Whether this is angina equivalent or not, that pro-BNP again will not answer the question. So, and then the risk prevention, you already said that you want to go out and out, just like what you would do for a regular patient. Let me ask my other attendees for their opinion. Dr. Chandramukhi is here. Dr. Chandramukhi, I believe you heard the clinical case. The questions for you also is same. How would you do ASCVD risk assessment on him, and whether you would go more active management on him or whether you would just let him be? And is there something you would do for the dyspnea? Dr. Chandramukhi, you can please unmute yourself.
Good evening, all. Sorry, Anup, I could not. I joined a little late, so I could not get the presentation of the patient.
Ma'am, I will detail the patient's presentation one more time for people who joined later as well, so that we can engage in discussion. This is a 76-year-old male who came to see me in the OPD last week. He didn't have any comorbidities till that time. His main complaint was dyspnea for 2 months, which on my physical examination, I did not suspect heart failure. I had some crepitations which were scattered around the lungs. I'd ordered some preliminary investigation, and I'm only sharing with you the relevant for today's discussion, which is HRCT suggestive of ILD, which answered my question of why this patient was having shortness of breath. His LDL of 143, non-HDL of 185, and a calcium score of 800. Rest of the labs parameters, A1C, ECG, echocardiogram, normal. So the question that we are trying to discuss in a 76-year-old male who is having dyspnea, which to me seemed to be more pulmonary in origin, and is having atherosclerotic risk factor numbers, which are quite high for what we have a standard, which is high LDL, non-HDL, as well as calcium score, but age, 76-year-old male. So the question here is, how would you categorize his ASCVD risk? How would you put him on some pharmacotherapy for primary prevention? Would you do any other ancillary investigation? And would you be aggressive enough to do a coronary angiography to look for stenosis for him? So this is the discussion that we are currently revolving around. And if there is anything you want to do for dyspnea, which I haven't done. All yours, ma'am.
Yeah, like in assessment of the risk, I would also like to do the HSCRP and see how is the HSCRP. And if HSCRP is also elevated, then like I would like to do the coronary angiogram considering his age and statins, this lipid profile. And like already his lipid profile is like a high LDL and levels. So I would like to start statins in this case.
Perfect. Thank you so much, ma'am. Ma'am, would you do angiogram now or would you give him some time and then do it? His calcium score is 800.
Any I don't know how will be the stress evaluation helpful in this case. So does he have any symptoms on exertion, like exertional dyspnea? You told already, I think you told exertional dyspnea is
Yes,
there.
he has got resting dyspnea, which gets worse when he exerts, but no orthopnea PND.
And no angina. Okay, dyspnea may be
Yes.
the anginal equivalent as it was discussed already.
Right.
Yes. Yes.
Right.
Yes.
Yes. So
Is he a diabetic?
he's not a diabetic. His A1C we just checked is normal.
Okay, but still, if the HSCRP levels are also on the higher side, I would like to go ahead with the angiogram.
Perfect. Thank you so much, ma'am. I'm going to go through my attendees list. Dr. Srinivas, I hope you got the clinical case. If you could share your thoughts about how would you go about this patient?
Yes, Dr. Anup, with the available information, this is a 76-year-old male who already has a functional limitation with limited activity, is short of breath, and your echo is normal, and your calcium score is already 800, showing that it's extensive coronary plaques. Definitely, he would require statins to stabilize the plaques as well as to take care of the endothelial function. Though maybe aspirin for primary prevention after the age of 70 years, there's increased chance of bleeding. So probably I would still wait. And if I had information about the ratio of the total cholesterol to the HDL, probably that would have also been helpful rather than just the LDL and non-HDL. And since the coronary calcium is already 800, CT coronary angiogram would not be of much help because it's going to give a false judgment regarding the severity of the coronary artery disease. In future, probably if he is going in for any surgery, definitely he would require a imaging. Till then, since it is more favorable in terms of interstitial lung disease as given by the history of physical examination and functional limitation with minimal exertion worsening with a limited walk, I would treat him for the interstitial lung disease as of now with high dose statins to stabilize the plaque. I would still wait on aspirin. And then, yes, I mean, if in future anything required for surgery, definitely, yes, we need to do a coronary angiogram before taking him for any other procedure.
Sir, could you just walk us through your thought process for total cholesterol and HDL ratio, just for the completion sake? How do you take as a parameter for clinical decision making?
Yeah, see, I mean, your LDL cholesterol is your total cholesterol minus your triglycerides divided by 5 minus the HDL, right? And the non-HDL cholesterol is your VLDL, LDL, and IDL, the intermediate density lipoprotein, which are all atherogenic. So your LDL cholesterol here was 143 and non-HDL cholesterol was 184. So probably the VLDL and IDL together must be around 42. That is a presumption. And those who have a total cholesterol to HDL cholesterol more than 3.5, they have increased chance for future cardiovascular events. That's what the literature says. Here already this patient has extensive coronary calcium score more than 400, almost double than that. It's already 800. So extensive plaques are there, and he requires a high dose of statin therapy. Definitely HDL we are not going to address primarily. If in case we are addressing the LDL, that will take care of the HDL anyways. But again, if the triglycerides are high, probably we'll address the triglycerides, which is unlikely to be high considering the LDL is only 143 and non-HDL is say around 84. Triglycerides are not going to be really high. So we are not going to investigate further, but if you have that information, you can share with us.
Sir, I don't have the ratio right now with me because in my decision making, I don't take ratio as a consideration. So that is why I thought maybe we can briefly discuss about it. Anyway, let me move on. I will ask my other attendees to opine. Let me see. Dr. Praveen. Dr. Praveen, you are, I hope you can hear me. If you could unmute yourself and share your thoughts about this particular case that we are discussing.
Good evening, sir. Regarding this case, I would first evaluate the cause of dyspnea, sir. I would first do the NT-proBNP levels and see how is the value and all that. For me, I would again repeat the echo, sir. Even if the HRCT is suggestive of ILD and non-specific pathology of not being inflammatory, I would be checking whether there is any presence of aortic stenosis, which can be missed in this and can be the usual presentation. Considering his calcium of 800, there is every chances that he can be also having an aortic stenosis. So first initially I will be doing the BNP, sir, and then I will be rechecking the echo. Regarding the angiogram, considering his calcium level, I will be doing the angiogram at the same settings after the availability of the BNP. Hello,
thank
sir?
you so much. Yeah, thank you so much, Praveen. I think one point you mentioned, which I do want to emphasize, is the role of repeat echo at times, because so many times we have seen the echo report not consistent with what we have in the clinical finding. And more often than not, we don't have the images with us to review. So I think your point is absolutely well taken to repeat an echocardiogram. Having said that, the discussion of valvular heart disease, particularly aortic stenosis and whatnot, it does get picked up in physical examination, but I agree with you that more often than not, we assume that whatever we are doing, we are pretty good at it, but sometimes we may not be able to pick up either a finding or whatnot.
Sir, in this scenario, as the patient is having ILD and probably considering him to be having a barrel-shaped chest and hyperinflated lungs, they what you call the intensity of murmur can't be that much high enough. So,
Absolutely. Absolutely. And on the same line, these are the patients whose windows often are not very good. So a point well taken. Point well taken to repeat some of the assessments to analyze. But one thing I want to summarize, or at least speak up, gathering what all the attendees have been saying so far, is this thought of defining this person's coronary anatomy either through CT or through coronary angiography. I believe that comes from the fact that we are thinking this dyspnea could be angina equivalent, because otherwise I don't think any one of us would advocate doing a coronary angiogram in an asymptomatic patient. So the whole idea of the dyspnea being angina equivalent, that is another something which I do have to keep in mind. As I said to start with, that I was pretty convinced that this dyspnea is coming from ILD, but to keep our options open, that's certainly one thing to work upon. Let me get more opinion here. Dr. Prithvi, if you could, if you can hear me, please unmute yourself and share your thoughts about this particular case. The questions are the same. And again, about the whole idea of defining coronary anatomy. Is it something that you feel you are compelled to do it right now, or you can give him a pass?
Hello, good evening, sir. Sir,
Yeah.
actually, I joined just a few minutes ago, sir. So I don't know exactly about the case. So could you please share me, sir?
Yeah, so to summarize, this is a 76-year-old male whose presenting complaint is dyspnea. HRCT suggests ILD, interstitial lung disease. His LDL is high. His calcium score is 900. He's non-diabetic, non-smoker, no other risk factor. 76 male, no angina, but only dyspnea for the past 2 months. And on my physical examination, he does not seem to have fluid overload. So we are talking about a dyspnea, which I am thinking is all ILD, but whether it is angina equivalent or not, I cannot exclude. And secondly, which is my point of discussion today, is primary prevention of ASCVD in a 76-year-old male who has got some atherosclerotic disease burden based upon his calcium score. So how do you look at it, and how will you go about it?
So same thing, sir. Actually, 76 years old, non-diabetic and non-smoker, no other risk factors. So only CT score is around 800. So initially, I would also like to go with ILD treatment only. So if doesn't improve, then definitely angiogram is I'll advise, sir.
Would you do anything for his primary prevention?
Statin. Definitely, I would advise him statin, sir. High dose statin because of high CT score. So and treat ILD first, sir.
What is high dose statin for you, Dr. Prithvi, if I may ask?
Atorvastatin 40 or 80 mg, sir, and rosuvastatin 20 and 40, sir.
Perfect. Thank you so much, Dr. Prithvi. If you have anything else to add later on, please unmute yourself or raise your hand. And I'm going to go down my list. Dr. Shankar, if I could invite you in the discussion, and if you could share your thoughts about this particular case.
Good evening to all. Am I audible?
Yes, sir, you are audible. You are absolutely clear.
Good evening to all. This is an interesting case. Patient has got a progressive dyspnea for the past 2 months. Looking at the history, physical examination, if they are Velcro-like Velcro crackles, the dry crackles are there in the clinical examination, physical examination. That goes in favor of ILD. Physical examination, I'm telling. If there is clubbing. Second thing is HRCT is a gold standard in case of ILD. The pattern recognition are there. So UIP there, NSIP is there. So likewise AIP. So many patterns are there. So the typical pattern here, it is given as a non-specific interstitial pneumonia pattern. This is mostly associated with the connective tissue diseases and drug-induced in ILDs also, we get this type of pattern. And in case of sarcoidosis also, sometimes we get this type of pattern. And hypersensitivity pneumonitis. These are all apart from this, idiopathic may be there. So these conditions, they give a typical pattern of a non-specific interstitial pattern. The radiologists have got a clear-cut idea. Looking at the HRCT, they will tell this is UIP, this is NSIP, this is AIP, so this is RBILD. That is a pattern recognition by the HRCT. Even in that case, it is very difficult. Though it comes under the diffuse parenchymal lung disease, IIP or ILD, then if you don't recognize the pattern recognition in the HRCT, then we'll go for other investigations like they may be a little invasive, like VATS is there, video assisted thoracic surgery, or The simple is a bronchial lavage, bronchoalveolar lavage, that is BAL, or a transbronchial biopsy. We can get, so we can diagnose or we can confirm this pattern recognition into many diseases. See, ILD, it is not a single disease. More than 200 diseases are there in this ILD. So it is a very big task to go through all these investigations to arrive at a diagnosis. Still, we say that it is idiopathic. And the second thing is, so here I strongly go by HRCT findings. Looking at the pattern recognition, this is NSIP. So it is a case of ILD only. Then we have to investigate further. Second thing is, looking at his calcium score, it is highly elevated, more than 800 Augustin units. So it is a documented case of atherosclerotic vascular disease with calcified arteries. Third thing is the investigation. Regarding investigation, to few of our learned colleagues, they have told that the CT angiography, because the CT angiography in this case is highly insensitive. Even I've worked with some radiology people also earlier. If the CT, the coronary artery calcium score, if it is more than 400, they will deny. Even more than 300 also, they deny CT angiography because they cannot interpret along with the calcium lesions. So it is very difficult to interpret obstructive CAD along with the calcium score. This much of a calcium score. The CT angiography, even the invasive angiography, the catheter-based angiography also, it is very difficult to interpret the obstructive CAD unless we go through complex procedures like IVUS or OCT. Regarding that to plaque morphology, that is different enough. But here I suggest only we should take help of nuclear cardiology. The old one, the thallium test, the newer investigations are wherever possible, we can get them done. The SPECT, Dr. Anup will agree with me, I think. The SPECT sesame B is an ideal in this case, or even the FDG PET facilities are available. We can find out not only the regional and global LV function, but also the myocardial blood flow, they can be recognized. So I go for nuclear cardiology rather than the treadmill. He cannot do it all. The dobutamine stress echo, that is ruled out. Then the CT angiography also is ruled out here. Even the MRI also ruled out here, because during CT angiography or MRI, patient has to hold breath. Here it is very much dyspneic, and the tachypnea also there. The rapid heart breathing, rapid respiratory rate is also might be there. So it is very difficult to, patient won't be cooperative, and we cannot interpret what the results will be along with CT angio or MRI. So here I definitely go for to document the coronary artery disease. So we have to go for myocardial perfusion imaging with stress thallium, not stress thallium, even thallium at rest also we can do. SPECT sesame B or the tetraphosphine or FDG PET. Or nowadays, the advanced centers have got multimodal hybrid imaging techniques are there to find out the coronary artery flow, the global function and everything. So I go for the nuclear cardiology in this case. And third is here we have to primary prevention of this in this case is we should go for only statins. Statins are high dose statins we should give because there is a clinical and documented ASCVD is there. So it comes under very high risk. He needs high dose statins, high intensity statins, because the LDL cholesterol has to come down below 55 according to the ASC guidelines, or even our Indian guidelines also, Lipid Association of India, LAI guidelines. We have to reduce it to less than 50. So high intensity statins, they reduce 50%. If we administer high, it will reduce 50% of the baseline LDL cholesterol. Still, we may need even ezetimibe also along with this high intensity statin, but considering his advanced age, I put him on the low bracket range of high intensity statin, 20 milligrams of rosuvastatin along with the ezetimibe. We can achieve the targeted LDL level, LDL cholesterol level. And these are my things. Lipid management, the further coronary artery documentation, we have to go for the nuclear cardiology to see the myocardial defects, myocardial blood flow, global LV function and all, LV ejection fraction. Also, we can get accurate with a PET imaging. So these are my take-home points, because one is he has got definitely has got ILD. This is NSIP pattern. Probably it may be idiopathic, because there is no clear-cut history of CTD, that is connective tissue diseases like rheumatoid arthritis or SLE. So and there are no history of drugs. So sarcoidosis is unlikely, because we can see looking at the chest radiography and all. So here it is a idiopathic ILD. Then documented ASCVD with a high calcium score, and definitely it is a case of hyperlipidemia with so we should bring it to target level. And he needs further documentation of a CAD. We should go for nuclear cardiology.
Sir, before I let you go, one question. You already said that, I just want to emphasize. So you would target LDL in him as you would target in a 50-year-old? I'm talking about level 50, 55.
That's why I told.
Yeah.
The low bracket range. See, we say that this is 20 to 40, 40 to 80. We say that 20 to 40 is the high intensity statin. So we start with the 20 milligrams. Suppose if the LDL does not come down to less than 55, we can add the ezetimibe. Patient may not tolerate also, because the advanced age, this patient may not tolerate statins also. In that case also, we have to add the low dose of statin along with the ezetimibe. Ezetimibe is second added drug in this case to bring down LDL cholesterol to the target level.
Perfect. Thank you so much, sir. I'm gonna continue with my list. I have Dr. Santosh here. Dr. Santosh, if you could unmute yourself and share your thoughts about the case that we are discussing.
Can you hear me, sir?
Yes, we can hear you.
Sir, good evening, everyone. Sir, targeting LDL therapy in this patient, as sir said, is it for in primary prevention also we target the LDL, or only in secondary prevention we have to reduce it by 50% or 30%, moderate intensity 30%, or with high intensity 50%? That is my question. And in this patient, I consider a coronary angiogram first investigation, sir. And as a preventive therapy, we'll add at least moderate intensity therapy in this patient. Thank you.
Thank you, Santosh. I'm going to read one question which have been put up here. Is there evidence of carotid? Is there evidence of carotid artery disease or peripheral vascular disease? Srinivas, sir, I did not check for it, so I cannot tell you whether he has got disease or not. When I was examining him, I did not hear any carotid bruit, and I did not do a peripheral pulse examination. you said that in that case, early CAG to rule out CAD would be a good option. I concur that there are thought processes where established peripheral vascular disease can be a surrogate marker of concurrent coronary artery disease. Whether that should dictate anatomy evaluation or not, that I'm not sure, but certainly there is correlation for this. Okay, anybody has got any questions about so far we are discussing? I'll go to Somaraju sir for his opinion, but before that, any questions or any comments that anyone has? Santosh, I'm going to mute you. Shankar sir, you have anything to add?
The question of BNP is raised here. See, in this case of ILD, patient will have hypoxemia, then hypercapnia, then ultimately he will the hypertension, then RV load, and RV dysfunction may be there. So in that case also the BNP will be raised, NT-pro-BNP or BNP. It is not of use in this case, even to rule out any cardiac dyspnea or all, because there may be a component in this case of pulmonary arterial hypertension also will set in. Once already 2 months, 2 months of progressive dyspnea is there, and this is a NSIP pattern where there is a lot of inflammation and fibrosis in the lungs, and hardly architecture of the lung is seen here. So naturally, he is dyspneic even at rest also, I think. So BNP is of no value, I think, in this case, because the RV load is also gives BNP, raised BNP, NT-pro-BNP also.
Point well taken, sir. Let us continue our discussion. If I may ask Somaraju sir to give his opinion about what we are discussing so far and his comments on the discussion that we had. Somaraju sir, if you could unmute yourself.
Thank you, Anup. And I just want to know what is resting SpO2 like?
Sir, in the OPD, he was pretty good, 96 to 97, with a heart rate of around 80.
Exercise?
Sir, I did not check on exercise.
So if you ask me, the first requirement in this, actually he's only slightly older than me. And people of our age are not in the clinical trials anymore, and they are excluded. And having said that, number one, I will never go for an angiogram directly for him. I will want to, number one, I have doubts about even the diagnosis of ILD in him. Because CT, as is done in the routine manner, say sensitivity and specificity is less than 70%. So I will want to confirm and assess the severity of ILD first before we go further. And calcium score of 800 at this age is like, gray hair. And don't overreact to it and then start doing angiograms and all that for them. I will want to talk to him and the family how much more they want to know, and how much disabled he is. And if I find that ILD is not severe enough, then I will evaluate him for coronary artery disease. The first thing I will do is not angiogram directly, but I will do some form of functional testing. And one must realize that, say, you have to go by what type of security guard, by definition, is not physically very active. And how physically active he was before all these things happened. Is it just physical deconditioning and some lung shadows overinterpreted as interstitial lung disease? All those things have to be considered. I will want to talk to the radiologist and ask how confident they feel about the lung shadows or interstitial lung disease, etc. Then, so I start doubting even the diagnosis and the severity of interstitial lung disease, and then start from there, re-establish the diagnosis, assess the severity of ILD, and having known that only I will proceed further. And also I will talk to him and the family how much more they want to be investigated further. And secondly, high dose statins and high dose, all those things are not particularly relevant to person at this age group. If you just want to use some aspirin, a low dose aspirin and a low dose statin, there is no, I won't argue against it. But to rush to give high dose statins and try to bring down his cholesterol like as if he is a young 40 or 50-year-old person, to me is not a right approach. And conservative approach is the key. And first establish the severity of interstitial lung disease, as you already pointed out by some people. Interstitial lung disease is not one entity. And some of them are treatable, some of them are not treatable. And having established that, I will proceed further. And calcium score is no indication for coronary angiogram at this age group. Thank you.
Sir, you did mention about primary prevention. If you could just highlight about, like you said, you wouldn't give high dose statin, but how do you tailor therapy? Would you just put him on 10-20 of atorvastatin and leave it at that? Would you target a particular number? How would you, if you could just share your thought process at this age group?
If at all, if you ask me, if this patient came to me, I will give him rosuvastatin 5 or 10 milligrams and aspirin, nothing else, nothing more. And if these patients are also predisposed to side effects of not only aspirin but also statins, and if he doesn't tolerate statin, I will add ezetimibe as somebody suggested, the combination with rosuvastatin particularly, and leave him at that. And until I have more information on about interstitial lung disease first, and then coronary artery disease later, I will not go for an angiogram. I will do, if interstitial lung disease is not significant enough, then I will do a functional testing and then proceed further.
Perfect. Thank you so much, sir. And so I will tell you the clinical status right now. Right now, this patient is undergoing pulmonary workup to establish the ILD diagnosis. I have ordered a pro-BNP on him. I have started him on 20 milligrams of atorvastatin. I have not started him on aspirin. And I have not ordered any further cardiac workup on him, including stress test or any angiography right now. Few things which were discussed so far by various attendees, I just want to highlight. Number one, the role of CT angiography in patients who has a calcium score of more than 300 is highly debatable, because there the blooming artifact of calcium overestimates any coronary luminal stenosis. So certainly patients who have got high calcium score, we should not be advocating CT angiogram. In fact, many of the imaging centers, if the calcium score is more than 300, they would themselves cancel the CT angiography, or they would call the ordering provider and say, hey, do you want to still go ahead with the study? So that is one point which is well taken. Second, even to start with, the point of calcium score not being the indication of coronary angiography, I think that point is also relatively well established. There is some data to suggest that if your calcium score is more than 1000, and if you have to know coronary anatomy, that have to know is important, because that is based upon the clinical presentation, then you can go for an invasive angiography, because that calcium score of so-called more than 1000 puts you at a higher chance of having luminal stenosis. Again, not a higher chance of event or whatnot, but higher chance of luminal stenosis. The reason why calcium score and luminal stenosis often not correlate with each other is because many of the times you can have huge adventitial calcium, which will come up as a calcium score, but may not necessarily show up in your coronary artery disease. Somebody also mentioned about concurrent aortic stenosis. I think that is also very important, not to diagnose AS, but sometimes patients who have got huge annular calcium, and if their calcium scoring is not done properly, then that annular calcium can also be included in the coronary calcium assessment, and falsely your coronary calcium score would be high. So it is important to look at the aortic valve, not particularly to diagnose AS, that you would diagnose with physical examination, but to make sure the accuracy of calcium score is well maintained. Then somebody also mentioned about SPECT scan. I think that is.
Anup,
Yes,
can I interrupt you here?
yes, sir. Please.
I think Dr. Praveen made a mention of the echocardiograms and its limitations. You remember when we were working together, and even Praneeth also would remember, we always insisted on seeing the echocardiographic images ourselves as a routine, asking for a separate recording. So don't, as a clinician, you must insist upon it so that you don't make this type of mistake of missing aortic stenosis.
Absolutely, sir. I think that this reviewing echocardiogram, sometimes scanning yourself, sometimes asking a repeat scan altogether, I think that is probably the most important skill one can have as a clinical cardiologist, because so many times we have seen echo misreported, not particularly because the person who is doing doesn't know, but it gets missed for various reasons. People are in hurry, the windows may not be good. There could be a lot of reasons why echo findings are missed. So trust on your physical examination and look at your images. That is very, very important. So I was talking about the SPECT scan. I think that is very important and, in my opinion, underutilized. SPECT scan is my favorite. I order far more frequently on my patients. Particularly if your patient can exercise, then the exercise SPECT scan, these days we do it with technetium. We still call it thallium scan because everybody remembers it as thallium scan, but thallium as isotope is no longer used in most of the centers. We use technetium tied up with either a systemib or tetrophosphine, and they give a far better image resolution as compared to thallium. So these tests are very important. It gives you functional assessment as well as the perfusion imaging. So I think that those were more or less what we are talking. The question of LDL targets in primary versus secondary prevention. So Santosh, to answer your question, LDL targets are well established for secondary prevention. They are also reasonably well established for primary prevention in patients who are at the highest risk of chondria or of atherosclerotic events. Now remember, all of those numbers and all of those targets stop at age 74. It is not a magic number. It is just that they had to put a number somewhere, so they put 74 as the number. The idea here is that when you deal with elderly population, then we don't know how these algorithms apply. And in fact, there is this whole discussion about what kind of primary or secondary prevention we should be doing in elderly population. And I don't think we have very good idea. And that was my incentive of taking up this topic for today's discussion, because there are a lot of unknowns. What Praneeth mentioned early on is a lot of these data set that they were derived about 20 years ago, when the life expectancy was about 5 to 7 years lesser than what it is right now. So, right now when you see a patient in their 75, and if they're functionally okay, you expect them to live at least 10, 15 years, maybe even longer. And in those patients, the age-old primary prevention thought process that we had 20 years ago may or may not be applicable. We don't know. Maybe we need to be more aggressive in 76-year-old than what we are currently. I am still not that aggressive, but I'm questioning myself every time whether in those late 70s or early 80s, whether I should be more aggressive than what I am. I'm talking about primary prevention, not secondary prevention. But those were some of the discussing points that I wanted to bring up. And I cannot give you answers to the questions because there are no answers, and that is why we are discussing about it. But these are worth looking into or thinking about whenever you get these kinds of patients. I agree that ILD in this particular patient needs to be evaluated further. And maybe in the next week or so, I will get more information about this patient, at least clinically. Primary prevention wise, that is all that I have done. And with all this discussion, let me go back to my attendees who gave me their initial impression and see if they have something to add or something to suggest. So let me start with Praneeth. Praneeth, if you could unmute yourself and give me a thought process about what we discussed in the last 40 minutes.
Interesting discussion, Anup. There is definitely, I believe as a cardiologist, there is a bias towards evaluating coronary artery disease and a low threshold to do coronary angiogram. Most of the patients who, the cardiology colleagues who did a comment was all in favor of doing CAD evaluation. I also take the point which Dr. Somraj has said about not getting too excited about the calcium score, trying to look at it as a graying affair in particularly that age group. But definitely looking at the commonest things first, things which are quite obvious like ILD or something, try to pay attention to that and start treating CAD as well. Maybe not too aggressive, at least you start and see forward. It looks like a stable angina, so not have any risk of events as great as it is. So we can start slow, look at his response and accordingly investigate or titrate the response. That's what I could think into it.
Thanks, Praneeth. Yeah, I questioned myself that when I saw this patient first, why did I order calcium score on him? And truly speaking, one of the reasons why sometimes I order calcium score is more of a negative prediction rather than a positive rule in. So these cases, because at 75, 80, people don't develop of soft plaque and a plaque rupture. That typically is a more young phenomena. These patients, if they have coronary artery disease, they have a much more established coronary artery disease. So not having a calcium in the coronary bed at that age kind of pretty much, in most scenario, I wouldn't say 100%, but most scenario it would exclude any meaningful coronary artery disease in these cases. Because if his calcium score would have come low, then I would have totally ignored his LDL level, no matter what it is. At 76, I would not have even given him a statin. I would just let him be and told him that, sir, you enjoy the rest of your life. I don't think you need to get any primary prevention, even if your LDL is 150 or your non-HDL is 180, 190. I really don't care. So my intention of doing calcium score was more like this, because as what you said and what Somaraju sir said, that at this age, what do we make out of this 800 number? We have no idea. So a lot of unknowns, and that is the whole point of
I'll just add one thing here
Sir.
on the calcium score.
Yes,
Today, the concept is calcium score plus exercise testing of some kind to establish obstructive coronary disease. Calcium score alone doesn't tell you everything. Second component about calcium score is it also has a therapeutic value and in interventional cardiology. If somebody has a very high calcium score, that is also very useful to try to know if we end up having obstructive coronary disease in this person, the type of intervention you choose, the type of, say, rotablation, etc., intravascular imaging, etc., you have to choose, also is decided by the calcium score. And the calcium score is useful that way.
Perfect. Thank you so much, sir. So that was in the last few minutes, that was my rant about why I chose this topic and kind of summarizing what we have discussed. If there are any comments, any questions, anything about this topic that we can discuss further, Dr. Shankar?
Excuse me. Regarding the primary prevention with the aspirin, is it advisable? Because the large international random trials like Arrive, Ascend, Aspri, all have given a disregard to this aspirin. So they may reduce the CV events by 12%, but at the same time, there will be 99% increase in the major bleeding risks, like GI bleeding or intracranial bleeding. So, Dr. Somraju sir, to clarify whether to give aspirin in this person more than 75 years of age in the primary prevention, before documenting there is obstructive CAD in this case.
If you ask me, in this patient, we don't even know the diagnosis fully. It's no longer a primary prevention at 76 years of age. And in all probability, he has some obstructive coronary disease of some kind, the degree of which we don't know. And when you are giving aspirin, you are not doing primary prevention at 76 years of age. It is a secondary prevention already. And aspirin, I think, will at a low dose, with carefully monitored and continued, will be useful. Don't call it primary prevention at 76 years of age.
Thank you, sir.
That was another important topic which was brought up. Thank you, Shankar sir, about aspirin and primary prevention. And the 3 trials that Dr. Shankar mentioned.
And one point I want to mention
Yes, sir.
here regarding
Yes.
the ILD. We need not worry about, see, ILD means there is no end of life care. So here in this NSIP pattern, this is a very subacute process. Even if it is diagnosed by radiologists, by the pathologist, that it is a case of NSIP type of ILD, then even then it is a subacute process. There is a very good prognosis. Even if you give only 2 months of corticosteroid, here we can also establish. So if 2 months of corticosteroid therapy will give extreme good results in this case. So this I want to mention, this regarding the NSIP, the prednisolone 1 to 2 milligram per kg body weight for 2 months. It is more than enough to bring about very good results in this case. So this has got a very good prognosis. Even in the long-term data also gives that survival rates are more than 10 years, even after the diagnosis of NSIP type of ILD.
Perfect. Thank you so much, sir. It is 8:35. Any other comments? Maybe for 1 more minute we can take if somebody has anything to add or question. If we don't have anything, Praneeth, your closing comments on the session, and then we will be done after that.
Yeah. So those which are out of the so-called recommendations and textbooks reads individual judgment or individual assessment of the patient, knowing the patient thoroughly, what are his requirements, probably his looking in person about his longevity, his quality of life, and his requirement, and making a judgment on that. The data you do not fits into that criteria, we have to make interpretation based on it, and make a meaningful assessment to the patient depending on his requirement. That's what I could take it from here.
Perfect. Thank you so much, Praneeth, and I thank all of you for attending today's session. To the attendees, particularly those joining us for the first time, we would like to get your feedback. If you found the session worthwhile, may we request you to share it amongst your colleagues so that we can have more ideas to share amongst. We host this session every Wednesday, and so far we have been doing at 7:30 p.m. From April onwards, we will start it at 7 p.m. so that all our regular attendees, please mark this timing. I will put it in the invitation as well. So from April onwards, for every Wednesday, we will start our weekly huddle at 7 to 8. The link to join will be the same. I hope it will be the same. The recordings of these should pop up on the podcast or YouTube at some point. I typically lag behind uploading those, but you should be able to find it at some point there. And if you yes,
can I interrupt you here?
Yes,
is
sir.
Dr. N. Praveen, is he the same person who conducted the say quiz in TCSI?
Sorry, what is that, sir? What name?
Dr. N. Praveen.
Dr.
Yes, sir,
N.
he's the
Praveen,
same
he is
person.
the yes, sir, absolutely. Dr. N. Praveen is the same person who conducted quiz. Yes.
Dr. Praveen, I must congratulate you. I listened to all that, and it was a wonderful performance. Congratulations, and it's a great job.
Thank you, sir.
All right, everyone. And Praneeth, you are unmuted. Do you have anything to add, or can I close this?
You can close. I was answering Somrat, sir.
Okay, perfect. Thank you all for attending today's session. I will see you all next Wednesday. And again, reminding you from April, it's going to be 7 p.m. April. Till the time we are in March, we will continue at 7:30. Thank you so much, guys, for attending. You have a good night, and we'll see you next week. Thank you.